Thank you, Robin. I'd like to thank the program committee, too, for the opportunity to present today. This is an amazing forum, an amazing crowd, and a very interesting discussion so far, and hopefully it will continue here. So I was given the unenviable task of talking about reoperative surgery and healthcare expenditure coverage implications. Specifically, it's unenviable because there's not a lot of data out there. So then I added this last part, a call to arms, and we'll talk a little bit more about that. First, my disclosures. I did attend a meeting that Olympus paid for. I'm also the principal investigator on a patient-centered outcome research institute. And my other disclosure is that I did major in economics as an undergrad, but that was a long time ago. And since we're talking about expenditures and macroeconomics, I thought we'd kick off with that first. Economics 101, taking people back. So Economics 101, well, it's about price and quality. It's about quantity. It's about supply and demand and how these curves shifts. It's about macro versus microeconomics. So microeconomics is the study of economics at an individual, group, or company level. Macroeconomics, obviously, is the study of a national economy as a whole, GDP, measures like that. Well, what about in reoperative surgery? Microeconomics could be seen as why I should or should not do reoperative surgery, and I'll talk about that briefly. The macroeconomics is really, should reoperative bariatric surgery be done? Is overall patient health improved if we do reoperative surgery, or are those dollars better spent elsewhere in healthcare? So Economics 101, I'll be talking about micro and macro with regards to reoperative surgery. So here's the summary for today, microeconomics, macroeconomics, but really, should we be doing reoperative bariatric surgery? And I'm not just gonna put out a question on that one, I'm gonna put out an answer and what we should do about it and a call to arms of how to get there. So, microeconomics. Should we be doing bariatric surgery? Here's, getting back to a little education here, on price versus quality, marginal cost versus marginal revenue. And what is the marginal cost versus marginal revenue to me as a surgeon? That's not how we usually think, but nowadays we're becoming a little bit more corporate than we would like to be, with network forces breathing down our neck, telling us what service lines we should and we shouldn't offer. That's a whole nother story, but it's a reality. So we have to think about that. So we do need to be versed in some of this as well. So what does this mean to me as a surgeon who is deciding whether or not reoperative surgery should be part of my practice? It's long workups, going through reams and reams of paperwork. It's difficult patient selection. A lot of times the patients who show up are pissed off. They're angry at the surgeon who did it before. For one reason or another, they screwed up, they messed up, they were told this along the way. These are challenging situations you're jumping into. I'm not even going to talk about the medical malpractice aspects of it, not only for yourself, but more importantly for the poor person who did the initial operation. It's a difficult pre-approval process. There are many denials. The operations themselves are physically taxing. They're longer operations with higher conversion rates, and most of us are not necessarily you have to do conversions, but there are higher conversion rates, and that takes a toll on one as well, the patient and the provider. Longer hospital stays and times rounding and speaking to the family, higher complication rates, lower reimbursement, there are billing hassles and appeals in uncertain outcomes. That's a big frowny face, if I were to ever say. If you look at the microeconomics on that one, a big frowny face. If you look at these cost curves, you say the marginal cost of adding this to my practice is really high and the return is very low. That means the quantity is low and I probably shouldn't think about doing it. Except you can have a profound impact on some patients who are miserable. And that's why most of us are here. And so I think this really should be something we provide and something we should consider because you can have a big impact on some patients, and that's what we as physicians are trying to do. So that smiley face can outweigh that whole negative face, and that's my view on the microeconomics of whether or not we should or we should not do revisional surgery. But what not to do, to get dead onto the theme again? Well, you should not do revisions before you have expertise in primary operations, period. If you don't have an extensive experience in Roux-en-Y gastric bypass, then don't make your practice converting sleeves to Roux-en-Y gastric bypass. And this concept of I only do revisions on my own patients is really a bad thing. High volume means you should be doing better primary operations. So think about that for 1 minute. But also, if you're doing low volume, you have bad outcomes. We know that. and you don't dabble, and you shouldn't dabble. So there really is a role for people who say, you know what, I think you should be considered for that. It's not a big part of my practice. This person, X, Y, or Z, is the one who you should see from that standpoint. And that person who is a saint who will take this on, but they'll have the smiley face in heaven when they take care of some of these miserable patients. So volume outcomes is important in surgical care. And really, when you think about it, the microeconomic level about if you should take on this case, I only do revisions on my own patients, is a bad thing. And if you are doing revisions, this is the toolkit you really should look at. This is from the ASMBS. Look up Revision Toolkit ASMBS. It was put together and constantly updated, but it has a systematic review and outcomes that was put together on this. It has policy details, so broken down by the region where you are, what are the policy implications written up on the website that you should be considering with regards to the actual insurers who provide that care in your region. Has submission documentation, kind of letters that you can use and templates that you can use in order to submit with regards to that. A lot of information around coding is also out there. And supporting literature. So if you're going to back up additional conversations or discussions with the quote-unquote medical experts at the insurers, then you will have some information at your fingertips in order to do that. So a plug here, asmbs.org, toolkits, revisional. Just put in revision toolkits ASMBS, and you will find this. It's all on one page, and I think it's a great resource for people who are in there, but don't dabble. So let's get to the macroeconomics of things. Should reoperative bariatric operations be done? We looked at this data in another format a moment ago, but you can see that in the number of operations that are being done, 216,000 cases, that the number of revisions are close to 14%. And that percentage has doubled from 5 years ago. So this could become more of a problem. Now, we talked about the uncertain outcomes of the future of some of the sleeve gastrectomies, and as those operations mature, as that's the most common operation, as you can also see from this slide, with the number of sleeves being done at 58% and gastric bypasses at 18%. So as those operations mature, that number of revisions could become a bigger issue. Getting back to the economics of things, because that's my task at hand, and that was what I was told to do. So 13.9%, this is a back of the envelope calculation, okay? 13.9%, there's 216,000, that's 30,000 operations per year that are reoperative surgery. Looking at the literature, as I quote here from the economic impact of weight regain, you can see that the average with regards to bypass revisions and band revisions. We don't have a lot of data right now with regards to sleeve revisions, and that's something we're looking forward to getting to. But overall, it's about $32,000 average for one of those operations, a lot of times more than double of the initial operation. And that's about $1 billion total of healthcare that's going towards reoperative surgery. Back of the envelope macro numbers there. But what are the cost savings? I mean, it's one thing to look at the cost, but you have to look at the benefits. That's what you know, allocating scarce resources, that's what economics is about. So what are the cost savings for bariatric surgery? So this is a study on the economic impact of bariatric surgery, this Cremieux study. It was in 2008 that this was put out, many years ago. For any researchers who are out there, this is the study that needs to be redone today using today's operations and today's data. But that's just a little plug for someone who was willing to take this on. But this really assessed the time required for third-party insurers to recoup the initial investment from bariatric surgery, looking at direct costs, i.e. the return on investments. So this is directly attacking the insurers who are now making a lot of the issues around coverage to say, this is the information. How are you going to get those dollars back? What's your ROI, your return on investment, on having coverage for bariatric surgery, period? So in this, they looked at 3,651 patients. It was an employer claims database, so it's claims data. It's not great data. They did compare to matched controls. It was for 5 years. So that means that any reoperations or revisions within that time were included in the cost analysis. Now, longer-term revisions are not included, and that's a caveat of the study, but basically revisions are baked in to here with regards to return on investment. So I'm going to use that word baked in because that's a significant aspect of this study here. So this study did show that ignoring potential quality of life and length of life benefits, and we know as clinicians that's probably the most important thing that we need to measure better, is the quality of life, how well these people do when we see them back in the office and how it's completely changed that life. It's that SF1 that David talked about before, saying that they 100% satisfaction with the operation. That's meaningful. But not putting any monetary value at that, just looking at direct costs, they found that the bariatric surgery basically paid for itself because of the decrease in comorbidities within 2 to 4 years. 2 years was for laparoscopic, 4 years was for open surgery. Again, a little bit old data. Again, we need to redo this, but that shows when revisions are baked into the 5-year data, that even then, it is cost-saving to do bariatric surgery. Considering this more closely, it's really the cost of obesity versus the cost of bariatric surgery. And this, again, looking at the economic impact of weight regain as quoted here, breaking those areas down, the cost of bariatric surgery, you have to look at the success rate. And we talked about the difficulties defining that with regards to quote-unquote failure rates of 50%. That's a whole nother talk that I'd love to go on, and how that's an inappropriate benchmark for especially sleeve gastrectomy. When you see that our results are only at about 52%, that means a significant number of those patients will be quote-unquote failures. Again, I get away from this. But the cost of revisional surgery has to be taken into account. We see that it's more than twice the operation. The success rate of revisional surgery, data we don't have. That can look at the overall cost benefit from that equation. And the reality is we don't have a lot of that information. So should revisions be done? Yes, absolutely. We want to put a smiley face on the people who take care of those patients who are miserable and on those patients who are miserable. But the presumption so far that revisions are costly but necessary byproduct of very effective primary operations. That's what the Cremieux study says. Okay, yes, there's a small percentage and it's a necessary byproduct. That's why people are tolerating and currently covering some revisions. But if we don't prove that revisions are appropriate on their own accord, then our patients will be subject to non-coverage decisions for revisions based on known costs but unproven outcomes. This is the big but. That's why the but is big here. If we don't prove that revisions are appropriate on their own accord, then our patients will be subject to non-coverage decisions for revisions based on known costs but unproven outcomes. That's what we're seeing right now. Yes, bariatric surgery, we'll cover bariatric surgery, but this revision thing, maybe not so much. We're arguing, well, when you get a knee replaced and you need another knee replaced, they do that. When you have a CABG and you need a redo CABG, they'll do that, or a redo valve, they'll do that. Hell, when you have a kidney and it fails, they'll put another kidney in you. But they're reluctant to let you do reoperative bariatric surgery. They're unbundling it from the primary outcome and picking it out and crossing it off. That's our biggest threat. So I think we have a call to arms here. We need to determine the appropriateness of reoperative metabolic surgery. That's a woman's arm because 80% of our patients are female. The huge deficiency is in our data. And I think we just saw the data that's out there. And not to be a naysayer, but I'd like to poke out the problems here. Mostly single institution data. Mostly case series which are descriptive and not comparative. The cases published are a smorgasbord of indications for procedures, types of procedures. There's missing data on what was the existing anatomy to corrected, what was actually done in the operation. Was the pouch revised? Was the anastomosis redone? Was the limbs lengthened? There's a lack of standardized nomenclature, no CPT codes, so that's not specific. Lack of outcomes that are specific to the indications. Limited clinical effectiveness and only short-term complication rates. Limited power due to small numbers, especially when you break it down to subgroups of clinically meaningful questions. What does that mean? Whoops, need to go back. It means revisions are a fruit salad. There are multiple indications, multiple things done in the OR, multiple outcomes to follow. By the time you pick out the pieces of orange, you pick out the pieces of apple, you don't have a lot of orange to analyze. And that's a problem from a statistical standpoint. So revisions are a fruit salad, and we need to figure out how to get information around that. We need to be able to compare apples to apples and oranges to oranges. That means we need to define what an apple is and what an orange is. We need power. We need to capture a lot of cases to sort out this fruit salad. And collecting data for revisions is very difficult. The number of data variables are large. Data burden is a real problem. Data burden versus the data needed has to be carefully balanced with regards to this. So someone who's taken a great amount of time and effort to develop the National Data Collection Program through the MBSA-QIP, we're really trying to figure out how to tackle revisions using that National Data Collection Program. We don't want to overly burden everybody with data points on that standpoint, but we have a call to arms. We need this kind of information. So we have to create standardized nomenclatures, indications, standardized techniques and notifications. And the outcomes have to be related to the indications. It's clinical effectiveness. If the operation was for pain, did the pain go away? If the operation was for weight regain, did the weight get better? These are the questions we need to ask. Those are the outcomes we need to measure. So, indications, anatomic problems addressed, procedural details, outcomes related to the indications, all these things need to be looked at. How do we do it? So, Kelvin, here's the thing here. We have to develop standardized nomenclature and standardized data collection. We could look at observational studies or what was discussed before, clinical trials. I'll borrow a page from ACOSOG or others. So ACOSOG is the American College of Surgeons Oncology Group. And the oncology surgeons has really taken, when there's a new or novel technique, they put it into a randomized controlled trial. They will only do it if it's in a randomized controlled trial, and they get meaningful data around there to help them make decisions and for coverage determination. That's a very high bar. And is that appropriate for reoperative surgery? Well, fruit salad is hard to put in a randomized controlled trial. So that's one of our real functional problems here. So I would argue, even though that's the gold standard, and that's maybe what we could aspire to do, with fruit salad, we probably need observational studies of what is being done, prospective, multi-institutional, large studies. That's really hard. But we also have the best data collection program in the world that's procedure specific, and that's the MBSA QIP. So we have the functionality potentially to do that and pull that off. So that's the call to arms. We need to determine the appropriateness of reoperative metabolic and bariatric surgery. If we do not do it, the non-coverage policies will proliferate to control costs, and we will lose the opportunity to collect the data we need. If we don't do it right now when we have coverage, when they say no, we won't have the opportunity to study those outcomes. So we need to do this now. Thank you very much.